frequently, and has been a great colleague to work with over the years, and I asked him to speak this morning, and so he tried to pick a topic that would be pertinent to both the neurology and general surgery. So talking about urinary diversions and some of the cases we do together. So thank you very much for joining us, and we'll look forward to your talk.
Thanks. So I think almost everybody in the room knows me, so I'll just kind of skip my introduction, but just wanted to start with a brief outline of what I wanted to go through today. So I'm going to start with ureterointestinal anastomoses, largely because this is a portion of the case that occurs with all of these diversions, and so it's important to talk about them, and I thought starting with that was pretty reasonable. So after that, I want to talk a little bit about the different types of conduits, and then I'll go through some of the continent diversions, so both continent cutaneous and then orthotopic diversions. And then just briefly touch on some of the different results of these various surgeries and then some of the complications from these surgeries. So ureterointestinal anastomoses, just as kind of a broad stroke to sort of think about how well these work. So there's a 12.5% renal failure rate long-term on all of these ureterointestinal anastomoses, and that data is a 30-year data. A lot of our patients that we're doing this surgery on start out pretty sick, so they don't make it 30 years. But still, a 12.5% rate of failure is pretty high, considering the number of people we're doing this surgery on. So there's two main types of anastomoses, or ureterointestinal anastomoses. There's a refluxing and non-refluxing. And in the urology community, there's significant controversy as to which is the appropriate type of anastomosis to perform. There are pros and cons to each. So for the non-refluxing, it may prevent retrograde intestinal bacteria from reaching the kidney, so ideally preventing some cases of pyelonephritis. And then that's sort of supported by some evidence from the mid-70s that demonstrated that the amount of renal scarring in the patients who got non-refluxing anastomosis was actually reduced at 3 months. The sort of downside to a non-refluxing anastomosis is that it strictures more often, which makes sense when you think about it. You're trying to reduce or make that anastomosis tighter, and it ends up scarring down more often. There's also a refluxing anastomosis. So interestingly, in one study, they looked at patients where they attempted a non-refluxing anastomosis, shot a lupogram or some other sort of imaging that demonstrated that the valve system had actually failed. There's actually a refluxing anastomosis, so they had one refluxing and one non-refluxing anastomosis in this study, and the actual renal function of the side that had the failed valve long-term was actually better, suggesting that, of course, a refluxing anastomosis may be a better long-term surgery. The other thing for these patients is a lot of time we do these diversions for bladder cancer. It's not the only indication, but it is the main indication. And in those patients are at higher risk for upper tract malignancy as well. And so one way that we can avoid giving IV contrast dye in someone who may have compromised renal function is a lupogram, or basically a refluxing sort of retrograde pyelogram through the conduit or whatever we've chosen as a diversion. And that's obviously only possible with a refluxing anastomosis and helps with surveillance in those patients that need upper tract surveillance. So I touched briefly on strictures, and the most common cause, or the most common thought of cause for ureteral stricture is devascularization of the ureter. And so we spend a lot of time in the operating room trying to think about how we can maintain as much blood supply to that ureter as possible. So only mobilizing what we need, maintaining adequate periadventitial tissue. If you think about the blood supply to the ureter, it comes from the medial side until the iliacs, and then once it crosses the iliacs, it comes from the lateral side. But there's also longitudinal blood vessels that run in the periadventitial tissue. So preserving those longitudinal tissues will allow better blood supply to that ureter. Retroperitonealizing the bowel and the ureters can allow us to mobilize less ureter, allowing for a tension-free mucosa-to-mucosa anastomosis with less stripping of the ureter. Bringing the bowels to the ureters, again, allows for more bowel mobilization and less ureteral mobilization to allow for that tension-free anastomosis. There are other things that can cause strictures, though. So stones obviously can cause strictures by both direct injury and then increased inflammation in that area. Urine leak is a cause of significant inflammation in that area, and that can also lead to strictures. Radiation ties in with devascularization, but I wanted to list it separately as its own risk factor. And then obviously infection via inflammation. And then one thing to always think about is recurrence in all these, especially strictures that are difficult to treat or have been treated more than once. A biopsy is always a prudent idea in those cases. The left ureter is the more common site of stricture, and I think I talk a little bit more about that later, but if you think about it, our conduits are always on the right side, which means the left ureter has to be mobilized a little bit more than the right ureter, which means that it's more likely to be devascularized. It also has to pass posterior to the sigmoid, immediately adjacent to the aorta, and that's actually the second most common site of stricture as it crosses. So again, more common in anti-refluxing type of anastomoses. Most common site is at the ureterointestinal anastomosis. Can also occur as the ureter crosses the aorta. There's two ways to sort of manage this complication, endoscopically and open. The 3-year patency is about 75% for an open repair of a ureterointestinal anastomosis, and the 2-year patency for an endoscopic repair is 60%. Obviously, the endoscopic repair is less associated morbidity to that procedure specifically, but one thing to remember about an endoscopic repair of these ureterointestinal anastomosis is they almost always have to be antegrade because you can't get to the stricture retrograde through a conduit, which does mean putting a hole in the kidney to get down to the stricture. The rate of urine leak at ureterointestinal anastomosis is about 3 to 5%. If you use one of those soft stents, if anybody's rounded on a cystectomy patient, you've seen the stents hanging out of their conduit. Those reduce that rate to about 0%. We used to use harder stents, and because of the rigidity of the stent, there's probably some compromised blood supply and led to about a 10% stricture rate with those harder stents, but the softer stents don't have that same problem. There's two main types of urinary diversions as far as conduits that I wanted to talk about, large bowel and small bowel. And then there are other types of conduits. I'll mention them just sort of in passing. So the ileal conduit is what you'll see most often. It's what we do most often. It's what most urologists do most often. It's the simplest type of conduit. It has the lowest complication rate. We harvest a segment of bowel that's about 10 to 15 centimeters long and about 10 to 15 centimeters from the TI. That's sort of what the literature and the book teaching suggests. Practically, we end up harvesting probably about 20 centimeters from the TI. Generally, the bowel lays nicer, and the mesentery lays nicer to sort of give us the length and the angles that we need better at 20 centimeters, so we end up harvesting from there. And it's the length of ileum that we take is really much more dependent on patient body habitus. 10 to 15 centimeters is a very long segment for what we see. In a skinny person, I think we've done as small as 4 or 5 centimeters. There's some complications to having a long segment, especially as a risk of stomal stenosis. You can get sort of a dilation of the conduit, and then the bigger the conduit, the more dilated it can become, the bigger problem it can, things like infection ability to drain stones, all those things increase. We work to preserve a major arcade. I'm sure most of you are aware of this, but we transilluminate the mesentery to try and identify an appropriate vascular supply and then harvest. I believe I saw Dr. Moore do that first as a PGY2. And then we close the mesenteric defect to prevent internal hernias after we've harvested the ileum. Placing the stents through the conduit for the reasons listed earlier. And then something to think about is a duplex ureter. It may not be identified on preoperative imaging, not something that you're always thinking about, but can be a big deal, as the upper pole and lower pole of the kidney in a complete duplex system will run in the same sheath most of the time, which means devascularizing one or the other of those two ureters will cause a loss of approximately 50% of the renal function on that side. And there are some ways to adjust for that, so you can spatulate the two ureters, keeping them in their common sheath, anastomose the two ureters together, and then anastomose that to the ileum. Some just sort of general contraindications to an ileal conduit or relative contraindications. Extensive radiation. Obviously, you wouldn't want to use a piece of radiated bowel. Inflammatory bowel disease and short bowel syndrome. You don't want to take additional ileum if you can prevent it. The next type of diversion I'll talk about is a jejunal conduit. I'm going to sort of go relatively quickly over this because it's not very common, but may have some harder to control electrolyte abnormalities. And we'll talk a little bit about why that is later in the talk. Usually only used when ileum and colon are not acceptable. And then severe bowel nutritional disorders or really the ability to use anything else would be a contraindication to using a jejunal conduit. And the literature suggests 10 to 15 centimeter segment again. I've never done one, but I would anticipate that in practicality, you would adjust that to the body habitus as well, and then 15 to 20 centimeters from the ligament detritus. There are sigmoid colon conduits. So Dr. Moore actually brought this up a little bit earlier, but in pelvic exents, you can eliminate the need for a bowel anastomosis by using a sigmoid colon conduit and simply attaching the ureters to the sigmoid and bringing up that stoma. Some contraindications to this would be disease of the sigmoid, some vascular issues, and then pelvic radiation. You can also use the ileocecal conduit. This has a few advantages. One would be that natural valve mechanism of the ileocecal valve can allow for a little bit of better continence. And then you can also harvest the segment of ileum to bridge a gap if you're short on large bowel. And then a transverse colon conduit can avoid the radiated area. So obviously a lot of these patients have had prior pelvic radiation. And so that transverse colon is largely unaffected by pelvic radiation. And you can bring up a transverse colon conduit. I'm going to switch gears here a little bit and talk about some continent diversions. And the two types that I'm going to talk about are cutaneous and orthotopic. So just in general, some general considerations about a continent urinary diversion. It's important to have all these patients get appropriate colon cancer screening because you wouldn't want to use a diseased segment of colon in your diversion. And if the patient needs another operation at the same time, it's obviously important to know that going up front. Preoperative hyperalimentation, and that sort of ties in with the ERAS protocol, also very important for these patients. So absorbable suture use in all of these diversions is a really important point and a common sort of medical student PIMP question. And commonly the answer we get is that it prevents infection, but really it's stone formation that we're most concerned with using the absorbable sutures. And if I'm not mistaken, I think that even shows up on the AB site every once in a while. Patient selection is going to be a recurring theme in this section of my talk. This is a much higher risk diversion. The patient must be willing and able to catheterize their conduit if it's going to be, or their continent diversion. And so some examples of patients that are probably not great candidates are patients with MS, particularly frail. Obviously, quadriplegic individuals are probably poor candidates for this surgery. And again, all of these continent diversions need to be compared to the ileoconduit as the gold standard. So these patients can expect a longer hospital stay and more complications. So again, informing patients of all of these complications beforehand is very important. And then some of the types of diversions that I'll touch on, your ureterosigmoidostomies, orthotopic voiding pouches, continent catheterizing pouches, ileoreservoirs, ileocecal reservoirs, and colonic reservoirs. And I'll talk about some of the complications from these continent diversions. So again, patient selection. The patient's renal function needs to be below 1.7 to 2.2 as far as a creatinine. Avoiding prior radiation in these patients. Bowel disease would be a contraindication. Significant prior operations, hepatic function, any mental impairment. And I would put the caveat here of substance abuse that's not treated. Patients who can't be reliably able to catheterize, so if they're drinking and they pass out and then they don't catheterize their conduit or their diversion for 12 hours, you can obviously destroy a pouch. Recurrent urethral strictures, that's more specifically for an orthotopic diversion and the inability to reliably catheterize that. And then if they're just not going to catheterize, some people do not want to catheterize and just refuse to catheterize. Obviously, doing a continent diversion on those patients is not a good idea. If you're going to do an orthotopic, it's important to evaluate their external sphincter function prior to doing that case, as they'll leak if they get an orthotopic and don't have adequate external sphincter function, especially since you're taking away a lot of the passive continence mechanisms of the pelvic floor when you do, presumably, their radical cystectomy, as well as removing their prostate, which provides a significant amount of continence in older men. And then, obviously, if the urethra is diseased itself, you wouldn't want to do an orthotopic and allow for the malignancy to remain in the body. So some of the goals. So now that I've listed why you'd never, ever want to do this operation, why would somebody ever pick this surgery? So there's some evidence of an improved quality of life with a continent diversion. Some of the other goals with this continent diversion would be low pressure storage, so that the renal units are not affected by the storage pressures of your continent diversion. You'd need a high compliance, ties in with the low pressure storage, obviously. You'd want reliable continence. Obviously, it's important if you're choosing a continent diversion to get adequate continence. And then you'd want to prevent reflux or stenosis. Again, that's a little controversial, but I kept that in there. And then ease of catheterization for patients if they need it. So the first type of diversion I'll talk about is the ureterosigmoidostomy. It's the simplest diversion. It's first reported in 1852. So you'd mobilize the ureters as you would for a conduit, and then re-implant the ureters into the tinea in an anti-refluxing fashion is how it's commonly described. I should say there's some increase complication rate of ascending urinary infections the lower the segment of bowel that you use, simply as the flora changes and the concentration of bacteria change. You wouldn't want to use an irradiated pelvis, obviously, if you're using the sigmoid. And the patient must pass an oatmeal test prior to the surgery, which is simply the installation of 400 to 500 cc's of watery oatmeal, and then they need to stay in the upright position for 1 hour. That's simply to ensure that there's going to be continence as the consistency of the stool changes in the sigmoid. So there's some complications that are most often talked about with ureterosigs, and one is the one that's sort of most often brought up when you talk about ureterosigs is colon cancer. Anytime that you anastomose the ureters to any sort of bowel segment, there's a chance for, especially colon, there's a chance for adenocarcinoma. The mechanisms poorly understood. Some postulated mechanisms are formation of various nitrosamines from the fecal flora interacting with the urine, and then inflammation from the suture material is another postulated mechanism. And then the time frame for this colon cancer is about 10 years. So you don't see the colon cancer until 10 years after the anastomosis. This has been a heavily studied phenomenon. People have done anastomoses where there's no urine flowing through it, obviously in animal models. They still form colon cancers at higher rates. It's pretty unclear how that happens. Some various modifications to ureterosig is a sigmoid rectum pouch, an augmented valved rectum. You can take actually a patch of ileum and put it onto the rectum to allow for sort of a better bladder function of the rectum. And then you can actually try to reduce the surface area that's exposed to urine of the bowel. There's a hemicoque and T-pouch and a folded rectosigmoid bladder, which also allows for an increase in volume of your pouch, as well as tunneling the ureters to try and reduce, to create sort of a flap valve effect, to try and reduce the ascending infections. And this is just a simple schematic of what a ureterosig looks like. Relatively straightforward. So the next one I wanted to talk about is actually an orthotopic voiding pouch. So you create a large capacity low pressure reservoir and anastomose that reservoir to the urethra. Most of these patients actually Valsalva void, although there are reports of some people being able to use their bowel to void. Can be done in men or women, various intestinal segments, and then there's some complications specific to orthotopic voiding pouches, so that need to Valsalva can increase a hernia rate in these patients. There's also fistula formation, and then especially in women, there's a phenomenon of hypercontinence. So if you think about the length of the female urethra as being significantly shorter than that of the male urethra, there's a chance for the female urethra to actually kink off at your suture site, or like change the angle of the urethra. It's a similar mechanism as to why prolapse patients will sometimes have urinary retention. This is generally the reason why the pouch is often tacked to the anterior abdominal wall, to try and prevent that sort of flopping of the pouch back, which would be important if you're ever operating on one of these patients to know that often that pouch is going to be immediately or even sewn to the fascia. So again, patient selection is a huge issue in these continent urinary diversions. There's some patient-related factors. So obesity actually may help in orthotopic diversions. Often it's hard to bring up a bowel segment to the skin in an obese patient, and so using their natural urethra can actually help you bridge the gap. Functional status, again, is a huge issue in these patients. Urethral stricture disease, manual dexterity for the need to catheterize. And then these patients also have that same renal function limitation I talked about earlier. There's also some oncological factors. So urethral recurrence is something that we see relatively commonly. You need to confirm that there's no active urethral disease at the time of your surgery. And then locally advanced disease used to be a contraindication to this procedure, though that has sort of changed in more recent literature. So an ileoneobladder is one of these types of orthotopic voiding pouches. And I'm just going to kind of breeze through some of these types just to give you a sense of how many different types there are. We primarily do 2 different types of diversions here, but there are almost an infinite number being done. So 70 centimeters of ileum is harvested. You preserve the TI, and we'll talk a little bit more about that, but B12 is obviously a consideration with that. Spatulate the antimesenteric border, arrange the bowel in an MRW, and suture the edges together. You take about 1 centimeter of tissue to allow the anastomosis to the ureter and reimplant the ureters. There's a Studer's pouch, 60 centimeters of ileum. You then rotate that ileal segment 120 degrees, proximal towards the right retroperitoneum. The distal 40 centimeters is then made into a U, and the ureteral anastomosis is performed at the apex. And it's actually that ileal segment that gives you the reflux. And then you also make that cup cystoplasty, or prevents the reflux, excuse me. You make the cup cystoplasty and anastomosis to the urethra. There's a schematic here that makes that make a lot more sense. So a lot of the actual anti-refluxing mechanism occurs right here, and then there's your anastomosis. There's a Coke pouch using about 40 centimeters of TI, of ileum, and then you obviously detuberalize and remodel an ileal plate. And this actually uses a stapled ileal intussusception to form a one-way valve. It's fallen out of favor as those staples. The absorbable staplers are pretty cumbersome, and the non-absorbable staplers obviously can have stone formation as a foreign body in the GU tract. There's also continent catheterizing pouches, which are the continent diversion we perform most often here. It requires catheterization multiple times a day. Obviously, patient selection. It's been a huge theme. It's very, very important. But failure to catheterize can obviously lead to renal failure, recurrent infections, and pouch failure. You can use large or small bowel. There's many different types of pouches. Primarily, the stoma is either brought up through the umbilicus or in the lower quadrant, sort of below where a fan and steel incision was, or would be. The lower quadrant is obviously a little bit better for cosmesis. The umbilical is, I would say it's pretty adequate cosmesis in what we do most often. There's 4 major continence mechanisms to these types of diversions. So you can taper or imbricate the terminal ileum, but then you end up losing some of the ileocecal valve. You can do an in situ or transposed appendix, so you can tunnel it through the tinea, but not everyone has an appendix, or the appendix can sometimes be too short to bring to the anterior abdominal wall. You can intussuscept a nipple valve. Very few people do this. It has the highest complication rate. It's the most technically demanding. And then there are hydraulic valves, which I've kept sort of on the list for completeness sake, but they've been almost completely abandoned because of stomal stenosis. So I'm just going to touch momentarily on ileal reservoirs, ileocecal reservoirs, and colonic reservoirs. The Koch is the most common type in sort of history. 60 to 70 centimeters of small bowel is used. Proximal 15 centimeters are used to create nipple valves and intussuscept the bowel, using, again, a stapler to secure it in place. The last 40 centimeters is opened and actually used to create the pouch using that U shape. And then the ureters are sutured in, and that distal nipple valve is brought up as a catheterizable stoma. This is kind of what that means. You can see as the pouch fills with urine, this pressure would increase, which would actually then assist in your valve functioning by closing the valve. So as you needed better continence, your continence would get better. There's a bladder substitution. You can use a 40 centimeter segment of ileum. We've mentioned that earlier. I did want to take this moment to sort of talk about detubularizing. So you'll notice that in all of these types of pouches, the bowel is detubularized, and that's in an effort to try and actually reduce the amount of pressure that is transmitted back up to the kidneys through presumably a refluxing anastomosis. There's also a Mansura pouch, a T pouch, and then an ileocecal reservoir. This is what we do most often here, a modification of this. So we use the ileocecal valve as its a natural continence mechanism for these pouches. The mains pouch pretty much is almost how we do it. So we make a catheterizable reservoir, try and make a spherical configuration to allow for the most urine storage with the least amount of bowel. And then ureters in this case would be done under submucosal tunnels, and then the intussuscepted terminal ileum would be the continence mechanism. The pen pouch was the first one to use the appendix as the continence mechanism, and it's left on the cecum but tunneled through a tinea, much like a flap valve. And then the Indiana pouch is what we do most often here. So basically we do that mains pouch where we use the ileocecal valve. The difference here is we put some Limberting sutures in to reinforce that valve. It gives us improved continence of the valve and the pouch. There's also a Florida pouch, which is another modification. The Miami pouch, again, lots of different ways. This is unfortunately the best image I could find of an Indiana pouch and sort of how we do it. But where that Babcock valve is generally where we place those Lamberting sutures to try and reinforce the ileocecal valve. So there are also some more I wanted to talk about. So you can do a transverse pouch or a mains 3. You use the transverse and ascending or descending colon, create a U-shaped reservoir. So in patients with prior pelvic radiation, this can be a good option. And then their continence is obtained via tailoring a bowel segment to the anterior pouch wall. So there's various continence rates for these catheterizable pouches, and these are generally have better continence than the orthotopic neobladders that I talked about earlier. Appendicean ileocecal stomas have better continence as opposed to an intussuscepted ileonipple. And nighttime continence rates can be about as high as 20 to 50%. But as that pouch stretches and you get better volume out of the pouch, you end up with better continence rates. And I sort of put this chart up just as a general guide of what's reported in the literature for continence rates. So one of the main reasons I said we'd potentially do this procedure that's more complicated, has a higher complication rate, and is more technically demanding is quality of life. So multiple studies have looked at this to see if the juice is worth the squeeze, as it were. And they've generally shown that patients are happy with their continent urinary diversion. There have, however, been no well-designed, well-done long-term quality of life studies comparing a conduit to a continent diversion. Some of the smaller series will suggest both ways. So it would be a good study to do to see if it's actually worth doing these surgeries. But then when you look at the quality of life between an orthotopic and a continent cutaneous diversion, there have been no quality of life differences between those two in some pretty reasonably good studies. Just in sort of passing, gastric segments have been used in the past and actually have some advantages. People have done minimally invasive intracorporeal continent diversions, so robotic technique. This is particularly attractive in women, as you can pull the bladder out of the vagina, and then it's basically only your port sites that you would have as incisions for cosmesis. It does take a long time to do, however. It's a lot of sewing to do an intracorporeal continent diversion. And then I touched earlier on absorbable staplers. That may allow for reduced suturing time. However, they're pretty cumbersome to use and hard to actually use technically. So there are some metabolic complications to all these diversions. And just as a general rule, the longer the urine is touching the urinary diversion, the worse the electrolyte abnormality. So for the most part, it's safe to say that the pouches have a higher metabolic complication rate than the diversions, like the conduits. So there's some electrolyte abnormalities, and we'll get a little bit more in depth on those in a minute. Some altered sensorium, some abnormal drug metabolism, particularly important for dosing things like chemo, osteomalacia, some growth retardation. That's primarily in pediatric patients who need augments, things like that. Persistent recurrent infections, renal calculi, and urethral intestinal cancer that I talked about earlier. So things that change the metabolic complication rate, so the type of bowel used, and again, we'll talk a little bit more in depth on that in a second. The surface area of bowel used, the time the urine is exposed to the bowel, the concentration of solutes in the urine, and the renal function and the pH of the urine. So the stomach generally leads to a hypochloremic, hypokalemic metabolic alkalosis. This can present with lethargy, respiratory insufficiency, seizures, and ventricular arrhythmias, but presumably it is preceded and usually is preceded by vomiting, leading to diarrhea. So usually this is not a significant complication unless the patient has developed some concomitant renal failure, leading to significant impairment in bicarb excretion. So H2 blockers and PPIs are often adequate to prevent some of these. However, if it's unable to treat the metabolic complications, then removal of the gastric segment may need to be performed. And gastrin levels will play a great role in the amount and significance of these metabolic complications. Dehydration from the vomiting. What happens is basically dehydration results in some increase in aldosterone. And then that increase in aldosterone in the setting of hypokalemia and hypochloremia will lead to an inability to clear the excess bicarbonate in the kidney, along with the excess bicarbonate produced in the gastric segment. And basically that circumvents the normal homeostatic mechanisms of the kidney. So as the gastrin levels increase, the amount of effect they have increases, and kind of the key number here is 120 nanograms per liter. You also have to remember that if you're going to use the stomach, then the stretch mechanism for release of gastrin in the stomach is going to be triggered by the urine, and that can end up changing your metabolic complication rate. The jejunum tends to lead towards a hyponatremic, hypochloremic, hyperkalemic azotemia with acidosis. And basically this results from an increased secretion of sodium and chloride with associated absorption of potassium and hydrogen. The loss of water increases the renin and aldosterone. This results in low sodium urine, leading to more sodium excretion from the jejunal segment, and can result in lethargy, nausea, vomiting, dehydration, muscle weakness, and elevation in temperatures. Hyperalimentation solutions actually exacerbate this, There's no known mechanism for this exacerbation, but it's good to know prior to starting in a hyperalimentation in these patients. The incidence will vary with location of jejunal segment. Proximal segments represent the highest risk. And simple rehydration with sodium chloride and sodium bicarbonate with possible long-term thiazide diuretic use is generally the treatment of choice. So the ileum and colon I've put together because their general metabolic complication is the same, which is a hyperchloremic metabolic acidosis. Generally doesn't have a significant effect, but if it gets severe enough, you can get some easy fatigability, anorexia, weight loss, polydipsia, and lethargy. And basically, ammonium substitutes for sodium in the hydrogen-sodium antiport, and ammonium chloride, is therefore absorbed across the lumen into the blood in exchange for the carbonic acid. Alkalizing agents can help treat this, or any blockers of chloride transport. The hypokalemia is caused by loss in the renal unit, potassium loss in the renal unit. And the hypokalemia is actually blunted a little bit by the ileum, which will absorb some of the potassium, but the colon will not do this. This is one of the proposed ways in which proposed mechanisms for why the colon ends up having worse and more severe metabolic complications than the ileum does. It's also important to remember that there's some abnormal drug absorption. So any drug absorbed by the GI tract and excreted unchanged by the kidneys obviously poses the most risk, as that drug is going to be then re-exposed to bowel mucosa. And in patients with continent diversions, particularly those receiving chemo, this can be exacerbated as that urine may sit in the diversion for 4 to 6 hours. And so keeping these patients drained allows for a decrease in the risk of this overabsorption of the drug. So osteomalacia is another risk. Mineralized, and this is sort of a longer-term risk, but mineralized bone is reduced and the osteo component becomes excessive. This results in lethargy, joint pain, proximal myopathy. It's likely related to the acidosis, vitamin D resistance, excessive calcium loss. Infection is obviously also a risk. So bacteremia and septic episodes occur pretty frequently. And about 13% of these patients will end up having a septic or major infectious episode after their surgery. This is probably a little bit different. This is data from 1970, but it was the best study I could find. Cholecystoplasties would have a higher risk than ileocystoplasties for some of the reasons that we talked about earlier. And pyelonephritis occurs in 10 to 17% of patients with a diversion. And in one study done in 1973, 4% of all the patients who got ileoconduits died of sepsis, presumably from an ascending infection. Another thing to remember when seeing these patients is that because there's an ileal segment, their urine is going to have positive urine cultures most of the time, about 75% of the time. And usually that's not a big deal unless they're symptomatic. You wouldn't treat it unless they're symptomatic. There are 2 species, however, that get treated regardless of whether or not they're symptomatic, and that's Proteus and Pseudomonas species, simply because they have a higher risk of sepsis and so end up getting appropriate prophylaxis. One more complication is stone disease. Primarily, these are magnesium ammonium phosphate stones or infectious stones. And so pre-existing infection and recurrent infection can predispose you to these stones. The metabolic acidosis contributes. There's also potentially foreign bodies in the way of staples or sutures. And then simply the bowel mucosa producing mucus can serve as a nidus for stone formation. There's also some intestinal changes and nutritional problems. So I touched momentarily about B12 malabsorption, and This is a large reason why we try to maintain as much TI as we can. Anemia, neurologic abnormalities, and then, of course, delayed 3 to 5 years secondary to stores in the liver. Poor absorption of bile salts after removal of some intestinal segments, particularly the ileum, and then the ileal break, so the slowing of the bowel function when the fat comes in contact with the ileal mucosa is lost, and then irritation of the unabsorbed bile salts in the colon, causing the colon to become irritated. I touched on this earlier. I'll just sort of breeze through this again. But again, urosigs, about a 10% rate at 10 to 20 years of development of an additional cancer, as well as some adenomatous polyps, sarcomas, and TCCs. And again, the mechanism's not well understood. Oh, one thing I should mention is if you're going to defunctionalize a segment for whatever reason, it's important to remember this cancer risk, so you make sure that you excise the anastomosis to try and reduce that risk in the future. There's some volume and pressure complications. So any segment that's defunctionalized will decrease. Any segment that's actively being stretched by urine will actually increase in volume over time. And then splitting the bowel in the antimesenteric border allows for decreased pressure in the kidneys and a refluxing anastomosis. Interestingly, after about 3 months, initially the contractions are not coordinated to the bowel, but after 3 months they actually are. They regain their coordination. And with that, I'll entertain any questions. Does anyone have anything?
I've got one. That was a very good, thorough talk of all kinds of things that we see frequently. So if you have a patient with a continent pouch or continent diversion who has manual dexterity and all this, and let's say 5 years down the road they have a stroke and they're no longer able to do that, is this something that you could just leave a catheter in place, or would that lead to complications? What would you do with that patient who is a candidate and becomes not a candidate after the procedure?
Yeah, it would depend on their overall functional status, prognosis, and their disease. But most likely what we'd do is, if we can, convert them to a conduit, just to try and continue to reduce the risks associated with, if his catheter falls out or her catheter falls out, or the infection risks of having a catheter. Basically, you're arguing forever would be so trying to reduce that risk as much as we can. Some patients aren't going to be candidates for that, and then we have to come up with creative solutions. But in an ideal case, that's what we'd do.
I thought that was very good and exhaustive. My question is, if you're using colonic segments for any kind of pouch, is there some standard screening mechanism by which you catheterize the pouch and look? Because there are some articles out there on carcinomas that have formed in diverted colons. Is there any regular screening?
Absolutely, yeah. There absolutely should be. That was part of why that leupogram was so important, because part of the screening process is CT with contrast, which repeatedly can cause some significant renal deterioration. And the leupogram presumably helps you get the upper tracts. But yeah, these patients are generally, should be scoped.
I mean, you do have scopes that you can look, right?
Mm-hmm.
Okay. So,
yeah, absolutely.
And what, would you do that once a year?
Annually, eventually.
Yeah.
Initially, it's a little bit more frequent than that. I can't remember exactly initially, but eventually it gets to annual.
Now, you mentioned we do a lot of Indiana pouches. Looking at your statistics there in terms of how they work, why do we choose the Indiana pouch?
Yeah, so the continence rate for the Indiana pouch in the literature is less than some of the other continent diversions. Some of that is how the pouch is done. So you're using both the ileocecal valve as well as those Lamberting sutures. And I think, because I've asked this exact question, and the answer I got was that basically not everyone puts the Lamberting sutures in as tight, because there's a risk of being unable to catheterize easily if you basically obstruct that, which is a big concern, require major operation to fix. And so that was sort of the response I got.
I think one of the things we would probably encounter would be the issue about infection. And you said it was how do you decide who has an infection? When you're talking about complications, I mean.
Yeah, so clinically symptomatic. A UA, urine culture, are not going to be very helpful, because 75% of these patients will have positive urine culture. So fever, white count, clinical suspicion. Some patients can actually have some abdominal pain, which is helpful, but not everyone is going to have that. And then it's clinical judgment.
So for us as general surgeons, you're going to have to empirically treat people. I mean, we would go through, I assume, excluding diverticulitis and all those kinds of things. If they still had an appendix and you hadn't used the appendix already, appendicitis and whatever, or other problems, GYN infections, I guess. The gas. How do you use the stomach? The urine just flows into the GI tract, or what do you do?
No, so you'd harvest you actually can harvest a segment of stomach, and then.
So the anatomy of that is you make a tube out of part of the stomach, and okay, all right, I didn't understand that. Okay, but that's not frequently done, I was saying.
Certainly not here, and I don't think anywhere else.
Okay.
There are some specific complications to that too that I
for the most part, then the ileocolonic. One version or another are the most common that you see. I mean,
absolutely.
When we get called to help you guys, it's usually for that, right?
Absolutely.
Okay. So, leaving here, that's the most common thing. And the cock pouch is not used now. What was the problem with it?
So it had an exposed staple line, and there's some concern for stone formation on those staples.
Permanent staples more than anything.
Yeah.
Okay.
Historically, when coke pouches were used for, small bowel diversion, the reoperation rates were so high because of the nipple valve slippage problem. So I would imagine that, and then there were techniques where they would go back in and they would take the pouch down and totally rotate it and make another nipple valve and plug it back in, and the reoperation rates are pretty high just from the mechanics of the way the pouch is supposed to work. And then if you add the necessity for staple lines to try to stop the nipple valve slippage, then it doesn't work very well.
Yeah, I remember when coke pouches came out in the 60s and 70s, and, everybody thought it was going to be...
it's still pretty good in some centers, for
really?
small,
okay, I was just curious because we sure had problems.
You'd really want to do it at a...
Yeah.
And then a Barnett modification came out. So there are some specialized places where highly motivated people can still get a pouch that's got so much
in that case, for the residents,
structure.
those are patients with small bowel disease, short bowel, inflammatory bowel disease, that sort of thing. It's the reason you do it, yeah. Okay. Other questions or comments? Well, Nathan, thank you very much. Very well done. Very comprehensive.
Thanks for having me.
Appreciate you being here.